So let's talk about actually how to taper. You've got a patient, let's just say, who's taking 4 milligrams of clonazepam a day. I'm making it easy because the other ones are a little trickier. Physiologically, the best bet is, first of all, you have them on a long-acting benzodiazepine, which self-taper anyway. That's clonazepam or diazepam. They have long-acting metabolites and they taper themselves. Then use a fixed schedule with symptom-driven tapering. So number of hours of sleep and vital signs, not so much subjective states, although those can be important. A lot of support's helpful. And then there's different numerical procedures, 10% per week or 10% per month. You follow the vital signs and symptoms. And again, the long tail means if you're going from 4, let's say, to 0, you might go 3, 2, 1, 0.5, 0.25. So you drag out the last part because it's that last little nubbin that can be most difficult physiologically. And that's just kind of and again, if you want to add an adjunct to a medical adjunct that can be helpful. So this is pregabalin or Lyrica. I apologize. On my computer, you can read the top line on the screen. It's hard to see. Pregabalin was approved in 2006. I remember it being very expensive, but it went generic in 2019. And although insurance will still give you grief about it, typically, that you can use a GoodRx coupon and get it for, maybe $20 or $30 a month. It's got a bunch of indications, and it's indicated for generalized anxiety disorder in Europe. It's renal excretion, no significant drug interactions, and it, as a drug, is more potent than gabapentin and faster absorbed with greater bioavailability. So I remember back in the day when I was using gabapentin and maybe the patient didn't have a good response, and I was like, oh, I wish we could get Lyrica, but it's too expensive. And now you can get it for much cheaper, and I find it just a better drug. All of this is off-label, by the way. Lyrica is not indicated for benzo withdrawal. It's not indicated in the United States for generalized anxiety. So caveat emptor there. Let's review the bottom line, and then I'm going to have some time for questions. So obviously, as you do with any patient, before starting benzodiazepines, do a careful short and long-term assessment of the risks and benefits, including the risk of medical tolerance. Remember, that's our term for the patient dutifully takes the medicine, but can't stop without experiencing withdrawals. It's likely that the risk of addiction and medical tolerance for benzodiazepines was higher than initially anticipated when those ads were coming out. And so that's something you want to tell patients about. But most patients don't get addicted to benzodiazepines, just like most patients don't get addicted to alcohol when they're exposed. And if a decision's made to slowly reduce or stop these medicines, if you make that in conjunction with your patient, follow a consistent plan and consider adjuncts, that is, other medicines to help out, pregabalin, gabapentin maybe, and also CBT. I didn't talk about that, but both CBT and CBTI, which is a program for cognitive behavior therapy for insomnia, which is recommended by the American Sleep Foundation and others, can be really helpful. So again, together we reviewed the risks and benefits of benzodiazepines, gave you a little tour through the history of these drugs. We talked about data regarding actual benzodiazepine use and misuse. And then we looked at benzodiazepine prescribing, safer use, and tapering. Thanks for your rapt attention today. I wish I could be here in person, walking amongst you, hopefully next year when science beats this virus. But in the meantime, thanks again, and I'll be happy for any questions. Take care.
Okay, Dr. McDonald, first I want to thank you very much for sharing your knowledge in this very important issue that we have here. Some of the questions that have come up are very, very important areas. So the first one is, what would you say is the difference or uniqueness about Xanax versus other benzos?
Yeah, so Xanax, of course, has a special place in the heart, probably of many patients, but of maybe some doctors as well. Although it's in the benzodiazepine family, it's got a different chemical structure. And as someone who's detoxed people from benzos for decades now, it does have one of the most unique withdrawal syndromes. So even though it's in the benzodiazepine family, has a unique withdrawal syndrome. There's some animal research showing that it's especially elevates the dopamine and the nucleus accumbens so that it's especially addictive. And the important thing for us to realize is, although I and others, I'm sure, have a sense that sometimes it's more potent than other benzos, all the head-to-head studies show that that's not really true. So, it's a drug, again, that's near and dear to my heart as an addictionologist, that it has that special glaze to it. But but it's no more effective and may have an especially high addictive potential in the benzodiazepine family.
Great, thank you. Next question, how do you manage patients that are using both marijuana and benzos for anxiety?
Extraordinarily relevant question. If you want to learn more about marijuana, I'll do a little self-plug, and I did a talk for the SDAFP on not cannabis. I think I did a cannabinoid and a CBD talk. But anyway, there's talks on YouTube about cannabis. But the first issue is when patients are using cannabis, I don't know what they're using. So I don't know if is it mostly THC, mostly CBD. If they're using a high THC thing, of course, part of the disclaimer is the same with benzos. Addictive substances, medical use is not really that well studied. We all know that patients find them subjectively beneficial, and they probably are helpful for some conditions depending on what it is. So when a patient's using cannabis, you don't know what they're using. And like a benzo, they're also using a potentially addictive product that has a withdrawal syndrome. So that's the first thing. The second thing is the literature isn't incredible, but there's probably an increased risk of sedation and cognitive effects of the two combined. We know cannabis has cognitive effects. I presented that benzos have cognitive effects. So that the two together have an increased risk. And so I would just do education in a motivational interviewing mode about the risks of both, that both have cognitive risks and driving risks and other risks. And then you throw a little booze in there and you've got a trifecta. So I would just educate the patient about the risks. Do I think someone who occasionally uses cannabis should never be prescribed a benzodiazepine? I think that's a little excessive. But because so many patients now use them occasionally now that they're not criminalized. But I think education about the risks of the combination is your best bet.
Great, thank you. Next question, somebody's comment is, I'm confused. Do we or don't we, or isn't there a risk of cognitive decline with chronic use?
So what the literature says is as follows. There's the risk of cognitive decline a la dementia, a progressive, especially Alzheimer's, doesn't look like it's been validated in multiple studies. So I don't believe that there's a risk of dementia based on the last study I showed. If you take a group who's on, let's say, 4 milligrams of Xanax a day, and take a matched group who's not on 4 milligrams of Xanax a day, the literature shows that you may find some cognitive differences in that group because of the Xanax use. Now, that doesn't mean that if you took them off of it, that they're going to have an increased risk of dementia. It's just on the benzodiazepine, there may be some differences in cognition and things. So I hope that clarifies. It's the difference between cognitive deficits on the medicine and the risk of dementia, which is a progressive neurologic condition.
Got it. Next question. What dose do you use of Lyrica for tapering off?
So it's a great question. A disclaimer, Lyrica is not FDA approved for any of this, but I find it a really helpful drug. So my standard dose of starting is 50 milligrams at night for a couple of days, then 50 twice a day. And then the literature shows that for generalized anxiety disorder, 150 to 600, if you're tapering, you can often work with 50 milligram intervals, increments. It comes in 25, 50, 75, and 100s. Of course, as I mentioned, it's not FDA approved for that. For older people, I like the 25s. And you can do 25, BID and go up in that interval. So that's the protocol I've used for years. I find it really helpful. I like it. And I didn't use it when it was on brand much because it was hard to get approved. But now, like I said, with GoodRx, you can get it for $30 a month. It's really a great alternative. And I think the kinetics are so much better than with gabapentin.
Thank you. Next question. Wasn't there a recent FDA posting about benzodiazepines?
Yeah, that's a great. It came up on my thing a couple days ago. I'm looking at it right now. It's benzodiazepines now. Interesting because you look at the history. Remember we had the 60th birthday of Valium. The FDA is just catching up. Put a boxed warning on benzos. It's a boxed warning updated to improve safe use, and they just augment. And again, keep in mind, a boxed warning is the FDA's most prominent warning. So this is like a big deal. get it right on the exam kind of thing. You know, and I'm looking at the posting right now, and it says, it just highlights the risk of abuse, misuse, addiction, physical dependence, which I call medical tolerance. Remember, if you walk away and use that term, I'm going to be excited because I think it's less shaming than you know, if you prescribe a medicine and the patient takes it as prescribed and then stops and feels like crap, they're medically tolerant. They're not addicted or dependent. But anyway, this FDA, going back to the FDA, physical dependence and withdrawal reactions, and it just highlights those. It says that and I think this is partly in response, if I was in the FDA's brain, partly in response to the opiate epidemic, and also partly in response to the monitoring studies from the ER and things that, especially, you know, the benzodiazepines are more used and misused.
Great. There's also a question in here about that you spoke about the risks and benefits of benzos, but what about the Z drugs?
Great question. Z drugs, you know, Ambien, Lunesta, Zolpidem, Xalapon, and Sonata, you know, I really helpful drugs. Obviously, they've been incredibly highly prescribed. They act at some of the same GABA receptors with more sedation and less anxiolysis. My experience as an addictionologist is people can misuse them, not as likely. The half-life just doesn't beget that, and they don't have the same qualities, but worth a warning and probably worth limiting to patients with addictive disorders. So I think we're almost out of time, and I want to thank everybody again for your rapt attention, and I hope you enjoy the rest of the talk.
Great, thank you very much. Before I log out, I just want to remind people, use the Q&A button for any questions you have. Also, there's a feedback button at the bottom where you can evaluate the speaker. And to get to each session, you can use the next session button on the side of the next to the title, or go to the agenda and click on the session. Thank you. Bye. Thank you.